And before we open up the floor, Dr. Berlin.
All right, thank you. Good morning, everyone. I'm excited to be here and very grateful. I'm hearkening back to my days in my PhD, or SCD actually, which was on the topic of publication bias. So not publishing results based on lack of statistical significance. So this has been kind of a passion for me for quite a while. So I want to start by asking the question, do we always need participant level data? And just as sort of a heads up, the message here is let's be careful about when we really do or don't need person level data. And so if all we're doing is asking this kind of overall question about treatment effect in general, then we're going to get the same answer whether we use participant level data or individual or summary level data, right? Just for this overall question, we're not getting back in and re-adjudicating events, just everything is exactly the same, then statistically we're going to get the same answer. So that's just kind of a little bit of background from the statistician that I used to be. But the point I think that's been made a couple of times this morning is that the data are not always the same. That when you get to the participant level, you may, decisions may have been made early on that you wouldn't replicate. So published studies may not, for example, have always done the appropriate intent to treat analysis in a clinical trial. Sometimes you want to do a proper time to event kind of survival analysis, and you can't often do that just from published data where all you have is a count of events and a numerator and a denominator. And then I think importantly, as has been noted already, is getting into this question of adjudication of events. So are the endpoints defined the same way in the different trials? Were they properly validated? So what I want to do is highlight some points that were really already made by Drs. Califf and Loader, particularly focusing on this idea of exploration of heterogeneity. And what do I mean by that? We know that for a given clinical question, that study designs, the specifics of study designs and the patient populations, certain aspects of how the treatment was administered vary from trial to trial. And we also commonly see that results of estimates of treatment effect vary from trial to trial. And the goal then becomes to try to understand where are these differences coming from. Is it some function of how the trials were done? Is it some function of the subgroups that were included in the trials? What's going on? So we get into this question of exploring predictors of treatment effects. So now this can be done at the aggregate level. So if all we have are the summary level data, then we can do things like if we want to know whether treatment works better in men than in women, we can look at the percent of males in the trial at this aggregate level and kind of examine the relationship between the percent of males and the treatment effect. Now, it turns out that this is an example of what's called ecological bias. And the message I want to deliver, I'll give you an example, is that kind of approach can go seriously wrong. So it's not just a matter of feeling more comfortable having the individual level data. You can actually get wrong answers. And there are also issues that I think Dr. Zarin mentioned in terms of statistical power. So the example I want to talk about is look, it's an old one. It was from my days as an academic before I started wearing my Darth Vader suit wherever I go. So this is looking at anti-lymphocyte induction therapy in kidney transplant patients. So this is kind of prophylactic anti-rejection therapy. So instead of waiting for the kidney to get rejected, you give the therapy on the same day as you do the surgery, right? We had done an aggregate level analysis, and then Linda Sezek, who was a fellow at the time, always nice to have a fellow to go out and do the groundwork. So actually contacted the 5 authors of the original studies and managed to get the person-level data, the participant-level data. One guy actually had the data in punch cards in his garage. So I think we've come beyond that. So the factor I want to just mention, which was the point of the publication that we got, was this panel reactive antibodies. These are a measure of immune system sensitization. So high level means you're sensitized and you're more likely to reject the kidney. And the message here, the bottom line kind of is that if you try to look at this at the aggregate level, you get confusing, inconsistent results. The results at 2 years differ from the results at 5 years. It's just not clear what's going on. When you get the patient-level data, the participant-level data, then you can do an appropriate analysis and find out that, in fact, treatment is extremely effective. So meaning like an 80% reduction in risk of rejection of the graft. So an 80% rejection in the people who are sensitized and no benefit in the people who are not sensitized. Okay, so that's an important thing to learn because it's only in the trials that the sensitized population was only about 15% of those who were treated. And these are strong drugs. They have consequences, unintended consequences, like lymphoma, for example. So you really want to try to focus the treatment on the appropriate population that's going to get the benefit and not the risk. And again, I think it's the key here is that that's something that we would have missed if all we had were the aggregate level data. And actually, to Rob Califf's point, what's interesting is you can look at these studies individually now and see this difference between subgroups consistently replicated across all of the studies. So it's not just an artifact of one of the studies. Another area that I want to highlight is the use of participant-level data in addressing safety questions. And I want to thank Rob for mentioning the erythropoietins. I'm actually going to mention an example that we participated in the oncology side, so not in the kidney disease. So this was in around 2008. One of the Cochrane groups came to the three companies, us, Amgen, and Roche, who make these erythropoietins, to look at, with a request for patient-level data to examine the mortality question with the erythropoietins in the oncology setting. These drugs in oncology are used for chemotherapy-induced anemia. So the findings are published in The Lancet. The advantage in this case of having the patient-level data was if all you have are aggregate level data, you can look at things like what was the requirement for hemoglobin level for entry into the trial? What was the target hemoglobin? So was it a high target or a low target? So you can look at those trial level characteristics, but you can't get down into the details of what was the individual person's hemoglobin level at baseline. So there's a lot you can do with the patient level data that, again, you couldn't do just from the aggregate level. And you do get different looking results depending on how you do the analysis. The advantages of adjudication were mentioned. I'll just throw in another example that with the people will be familiar with the SSRI antidepressants, where the finding was that there's an increased risk of suicidality in adolescents and young adults. So that came from starting with the patient-level data, where you had to get in and actually read the narratives and decide. And in the original analysis, FDA had outside experts, completely independent from FDA or from the companies, getting into the data and adjudicating these individual stories and deciding, was this a suicide attempt or a suicidal ideation, et cetera. And that ended up in a label change for those drugs. So I just want to raise one other question of whether there might be an intermediate step here. And this has been discussed some in the literature, is the idea of sharing clinical study reports. And these are much more detailed reports than you typically find in a publication, even an online publication where some of the data are provided in electronically. So this is the detailed analyses, the subgroup analyses, the sensitivity analyses. Did we pick the right statistical method? I'm out of time. I'll talk fast. So just as a kind of intermediate, quick, kind of low-hanging fruit, as they say, I want to raise this possibility for further discussion of whether we might at least gain some ground by disclosing the full clinical study reports. Because in addressing some of these subgroup questions, you'd actually get the data that you need from the clinical study report that you wouldn't typically get from a publication. And I think I had some comments about how do we do this carefully, and I think that's really the topic for the next day and a half. Just based on the experience that we've had, there are a lot of details, starting with just harmonizing data sets. I mean, you can't underestimate, you can't overestimate, sorry. It's a lot of work to get things, you're taking data from 3 companies, from studies that are 20 years old, and turning that into an analyzable data set was the first 90% of the work. And the 10% is somebody doing the statistics. So there are some non-trivial. And just how do you set up the dialogue between the data providers and the people doing the secondary analyses? How do you ensure that there's appropriate contribution to the science without undue influence? And I think I'll stop there. Thank you.